Good evening, everybody. I'll be sharing my screen. Very good evening. Today, I'll be describing how we went ahead with the surgical correction of a conoventricular contortion. Now, the background behind the rather fanciful title that I've chosen for this presentation lies in a statement by Dr. Van Praag, who describes the conoventricular part of the human heart as a professional contortionist. He is in fact describing a fact that we encounter daily in the pediatric cardiology OPD, wherein we find that whereas the atria are relatively fixed in space, the twisting of the heart tube during development to different degrees can result in various combinations at the levels of the atrioventricular connections and the ventricular arterial connections. And this, in fact, makes management decisions of these patients uniquely challenging. I'll be describing one particular case that we handled recently. This was that of a 9-month-old boy who came to us with a history of fast breathing. The mother described a cyanosis that she had noted when her child cried. There was a definite failure to thrive, and the baseline saturation was 86%, and there was clear clinical evidence of increased pulmonary blood flow. The child was tachypnic at rest and had hepatomegaly. This is the child's ECG that shows us prolonged PR interval, superiorly directed QRS axis, and biventricular forces with RV dominance. The child's X-ray showed us clear evidence of increased pulmonary blood flow. So at this stage, we knew that we were dealing with a mixing lesion with increased pulmonary blood flow. We went on with the child's echo. This is the apical 4-chamber view, which shows us that there is a large inlet VSD. There is left atrial enlargement. There is a definite straddling of the right atrioventricular valve, the tricuspid valve, and we can see chordae going on and attaching on the left ventricular side of the interventricular septum, and suspected chordae going on and attaching even to the free wall of the left ventricle. So this is something that we would describe as grade 3 straddling of the tricuspid valve. This is again a color interrogation of the apical 4-chamber that shows us that the myxomatous thickened tricuspid valve is also causing moderate to severe tricuspid regurgitation. When we look at the color flow and we see the streaming of the blood, we see that there is in fact streaming of blood from the right atrium to both the right ventricle and the left ventricle because of the straddling of the AV valve. So this is something that we would call double outlet right atrium. The great artery levels, there is transposition of the great arteries with anterior-posteriorly related great arteries. The aorta is anterior. So on echo, what we had found that there was abnormal connections at both the atrioventricular and the ventricular atrial level. There was double outlet right atrium with the right atrium draining into both the RV and the LV and transposition of the great arteries. So at this stage, we had the echo impression of a 9-month-old boy with a large VSD, definite significant straddling of the tricuspid valve with EGA and severe hyperkinetic PH. Now we went on to think about the management decision. So at this stage, we realized that single ventricular palliation is essentially ruled out because this is a 9-month-old child with severe PH, and this makes a cavo-pulmonary connection essentially impossible to function. So the only option we have if you want to correct this lesion is that of a biventricular repair. But then there was the issue that whether surgical correction was actually a viable option. Why? Because although an arterial switch operation could be done and there was hyperkinetic pH, the issue was that that of the straddle of the tricuspid valve and the malalignment between the IS and the interventricular septum would cause the placement of a patch very difficult, because the patch would be interfering with the tricuspid valve, and the chordae would come in the way of a patch towards the crux of the heart. So we went ahead and involved our surgeon at this level, and we asked him whether he would like to go ahead with the surgery. He did literature search, and because a biventricular repair was an option, and otherwise we would have to resign this child to medical management, there was clear evidence of increased pulmonary blood flow. He said that he would go ahead with the surgery. Operative findings were in fact corroborative. I'll only be talking about the straddling AV valve because the arterial switch operation was routine. There was a large inlet VSD, and there was in fact attachment of the tricuspid valve septal leaflet to LV papillary muscles, and so grade 3 straddling of the tricuspid valve. Possible surgical approaches were basically two. One was that the VSD could be repaired by attaching a patch to the left ventricular side of the interventricular septum and incorporating all the papillary muscles as much as possible on the right ventricular side. The other option was that the surgeon had read about was that the patch could be fashioned in such a way that there was in fact a passage that he left for the Caudy tendinae to attach to the abnormal papillary muscle in the LV. He went ahead with the surgery by the first method, that he went and resected as many of the anomalous papillary muscle in the body that he could, and incorporated the patch in such a way that as many of the papillary muscles in the body of the tricuspid valve as were possible were incorporated on the RV side of the septum. Post-op, we had a good result. There was an intact ventricular septum, intact ventricular patch, as we can see. There was still a grade 2 tricuspid regurgitation, but there was no mitral regurgitation, there was no arrhythmia, there was no left ventricular outflow tract obstruction, and there was no tricuspid valve inflow gradient, which are definite risks in this kind of surgery. This is the unobstructed left ventricular outflow tract, and there is no mitral regurgitation. The child had a standard post-operative stay in the ITU, was discharged home stable, and the pre-discharge echo showed good function, no significant MR, moderate TR, but no significant inflow gradient, and a good result overall. So at the end of this, we realized that the take-home message is that a detailed echo delineation of cardiac anatomy in congenital heart disease can actually direct surgical planning in such a way that we can make even seemingly inoperable lesions correctable. These are my references. Thank you.